I guess that many of the issues that people were talking about in relation to lower middle income countries are things that we worry about in high income countries, which is my area of expertise. So the issues of a continuity of leadership, a sense of direction from the government downwards, engaging the local community in health services, the debate about whether individuals should take more responsibility for their health. These are all things that are fairly familiar if you work on, say, European health systems. And I think one of the things I took away from the book was a recognition that each country gropes towards its own solutions in its own way. There is no perfect health system. I do a lot of work on countries like the UK, New Zealand, which are scenes of frequent healthcare reform. And I was thinking during the conversation, are those countries of instability, or is it actually that we have surface reform and deep stability? And I think you have a mixture of both. So if you take the English NHS, which is in turmoil, at least at the political level at the moment, we've not really deviated from the basic arrangement that we set in the 1940s, which of having tax-funded system, universal access, with a very strong focus on fairness. And yet we have had, since the late 1980s, a series of fairly major organisational structural changes. But I think the other thing that came through, which is related to continuity, isn't so much about reform, it's about the personnel. And we noticed that a number of the countries had continuity in terms of the bureaucracy and the leadership, the officials in the Ministry of Health. And I think that's also something that certainly the NHS needs to bear in mind. What I would reflect on from those poorer countries is the point that was made in the discussion and in the book, which was that just spending more money isn't necessarily the solution. So if you look among high-income countries, they vary quite a lot in how much they spend on healthcare, irrespective of whether it's publicly or privately sourced. And so when we debate endlessly about whether we're spending enough on the NHS, whether we're going into a period of great stringency, how will we cope, we need to bear in mind that the key issue is what we spend it on, not how much we have in total. The implication is that a period of economic constriction, if you like, of slow or no growth, it's going to be negative because of unemployment, not because we can't afford to provide good health services. I think it is in the consciousness of the big philanthropic foundations and the big global donors. But I think they're always tempted by the idea that, yes, but actually, what if we just made a breakthrough and we could just fix it? So, I mean, I think the example came up in the discussion about malaria vaccines. Yeah, strides are being made, but there's still the issue of how do you deliver them to the right people at the right time consistently. And that really is where the health system comes in, and it's almost like the invisible glue in the delivery of healthcare. It's the bit that a lot of health professionals, again in high-income countries, tend to downplay, ignore, complain about, see as an obstruction, but actually it's without that they wouldn't be able to do their job.